Now we are done with all the renal system. We'll move on to urinary bladder tumors. So the most common benign tumor in a urinary bladder will be a leiomyoma. Just like that of a esophagus, leiomyoma is the most common one. But if they ask for malignancy specifically, it is going to be transitional cell carcinoma. So the risk factors for this transitional carcinoma will be smoking, then various aryl amines like naphthyl amines and benzidine. Naphthyl amines and benzidine are risk factors for urinary bladder cancers. While other than that, you can also have polycyclic aromatic hydrocarbons like benzopyrene. And cyclophosphamide, which is one of the chemotherapeutic drugs they use for. Here it can lead to hemorrhagic cystitis. So hemorrhagic cystitis, and then it can even transform into transitional cell carcinoma. Then long-term usage of analgesics, it can trigger urinary bladder tumors. Then radiation history, all of this. And there is one specific parasite called as schistosoma hematobium. So schistosoma hematobium is one parasite which is going to be causing an increased risk of squamous cell carcinoma and not transitional cell. Okay, so S for S, remember, so schistosoma for squamous cell carcinoma. So some of the kids have actually made mistakes with these risk factors involved in bladder cancer last time. So remember these risk factors. Aryl amines and polycyclic aromatic hydrocarbons are major risk factors for bladder cancers. If they ask specifically for benzene, benzene is for acute myeloid leukemia. So that is a blood cancer. But if they ask about benzidine or benzopyrene, these are going to be aryl amines and polycyclic aromatic hydrocarbons, which are risk factors for bladder cancers. Okay. So coming to the genetics of urinary bladder tumors, you have two grades, low grade and high grade, which have entirely different pathogenesis. So low grade tumors usually have a papillary morphology and they have this FGFR3 mutation. So classical of low grade tumors of urinary bladder will be FGFR3 mutations, while in high grade you have either a T53 or a retinoblastoma, RB gene mutation. Okay. And classical features of presentation of this urinary bladder tumor will be painless hematuria. Like in a renal tumor, again here it will be hematuria, but it is painless. Last topic in this renal system will be malakoplakia. So malakoplakia, again this image based questions had been asked in previous year questions also. So it is an infectious condition usually seen in immunocompromised, and the infection is most likely to be caused by E. coli or protease. And here grossly if you see, they'll have yellowish mucosal plaques. So some raised kind of plaques will be seen on the bladder. And here what is the major pathogenesis is in immunocompromised people, they are not able to mount a proper immune response to these infections. So there will be defective phagolysosome fusions. So when this phagolysosomal function is not there, they are not able to clear out this infections. So that leads to kind of a chronic inflammation. So lots of macrophages, foamy macrophages come and accumulate trying to kill this organism. So accumulation of this macrophages is seen. So all of these cells which we see here are macrophages. So all of these cells are macrophages only. And inside these macrophages, if you see here, this one, so all of this is actually having some central laminated kind of dark blue color thing, and surrounding which we see a halo kind of things, right? So this is nothing but a Michaelis-Guttman body. So Michaelis-Guttman body, these are nothing but laminated calcium deposits seen in the lysosome of these macrophages. Okay, so this exact image was asked in previous as one of the questions. Okay, so other than that, one important thing is these malakoplakic Michaelis-Guttman bodies is not restricted to bladder. It can also be seen in other organs like GIT, brain, lung, bone, endometrium, kidney,